Welcome back. In this final eyepiece of keratoconjunctivitis sicca, you will learn of the investigations, treatment, as well as the entire summary of the rheumatoid arthritis and the associated keratoconjunctivitis sicca. Keratoconjunctivitis sicca is a clinical diagnosis, and we can do some investigations to reach this conclusion. And first of that is something called the tear film breakup time, or BUT. We do this by first instilling fluorescein into the lower fornix, asking the patient to blink once, and then through the slit lamp, observe with the cobalt blue filter until black spots or lines appear, as demonstrated in the middle and the bottom pictures there. Normal breakup time is around 10 seconds and above. 5 to 10 is marginal, and less than 5 means an unstable and abnormal tear film. We can also try instilling the rose bangle dye onto the eye, and this dye is famous for ironically smelling very bad. This dye has an affinity for dead epithelial cells as well as to the mucus. So this is actually a good way to see the extent of the instability of the tear film, and also to see the damage done by the dry eye symptoms. The final test that we'll cover is the Shermer test, and this is basically checking for the amount of tear film produced by putting a filter paper at the edge of the eyelid. The filter paper is placed on the eyelid for 5 minutes, and the amount of tear produced is quantified by how much the tear stain travels along the filter paper. As you can see in the picture here, around more than 15 millimeters without anesthesia is normal. Around 10 is slightly abnormal, possible shortage of tears, and less than 10 would be a conclusion for insufficient tear production. There are several options for the treatment of keratoconjunctivitis sicca, both pharmacologic and non-pharmacological. First and foremost, to preserve the tears, we can idealize the environment. This includes reducing the room temperature and also using room humidifiers to increase the humidity in the environment and thereby preventing evaporation of the tear film. We can artificially administer more tears via drops like sodium hyaluronate and povidone, and gels and ointments may last longer, like the viscotears and the lacrylube. Mucolytic agents like the acetylcysteine 5% drops, this may help break down any corneal filaments and mucus plaques, but this may cause irritation and induce further damage to the cornea. Another method we can use is to reduce the tear that's being drained. And remember how I said the tears are drained through the puncta and then the canaliculi and to the lacrimal sac. Well, if you occlude the puncta, then the tears will last in the eye for a longer period of time. We can also choose to administer topical cyclosporin, which comes in either 0.05 or 0.1%. And this is a well-tolerated and a safe new medication, which reduces the inflammation of the lacrimal tissue. And lastly, the oral cholinergic agents like pilocarpine can relieve the keratoconjunctivitis sicca as well. But this is typically used for xerostomia or dry mouth. For scleritis and episcleritis, the mainstay of treatment is to treat the underlying cause, or rheumatoid arthritis. So for recap, rheumatoid arthritis and ophthalmology is quite closely linked. Rheumatoid arthritis can cause systemic inflammation of the joints and involve the eye as a part of extra-articular manifestations. This includes the inflammation of the sclera and the episclera, and also cause keratoconjunctivitis sicca by affecting tear production. This is a flowchart summary of everything we've covered today. And these are the references of all the resources that we used to put this presentation together. Thank you for watching this video.